All righty. I hope you're not in a food coma. Little bit, yeah. I hope everyone has some coffee. We're gonna get started with our third panel of the day on peer and community support. So Philip Abul will be moderating the session. As mentioned earlier, she's co-lead of the service delivery stream in IATA and has been NCD advisor at MSF for many years. How many? Too many years. Okay. So anyway, I hand it over to Philippa to introduce the panelists.
Great, thanks. Hi, everyone. And I'm actually going to ask our panel to come and sit up here to join me, please, while I start the introduction. So while I'm doing that, I just wanted to share start with a personal note, because 2 days ago I was on the plane flying to Athens and I was trying to read an article on peer support to prepare for this panel, an article written by some people in this room and online, because I'm not the expert. There are many other experts here on this topic. But I failed to read it. And I failed to read it because the page was a bit blurry through my tears, because just before I got on the plane, I'd seen the news of the impending invasion of Rafah by Israel, where, as I think's already been mentioned today, 1.5 million people are living with nowhere really to flee with proper conditions. And then thinking, of course, of the completely neglected crises in Sudan. Again, huge numbers of people displaced, unable to access food, conflict, and so on. Not to mention Ukraine, DRC, Haiti, numerous other crises around the world. And I actually wondered whether I really could stand up and moderate a panel on this, conscious of these conflicts, and particularly some of them that we're really failing to stop when the world should be stopping them. But in the end, the populations in these settings are the reasons that we're here. And we're here because amongst the victims of the bombings and of the starvation and of completely preventable epidemics, there are quieter victims. The children and adults living with diabetes who are unable to access what they need for diabetes care don't tend to be the ones showing up on our social media feeds and our news feeds. And so these 2 days we're discussing really important topics about supporting these populations, these people living with diabetes in these settings, and important topics that we've already discussed, accessing medication and tools that not only keeps them alive, but hopefully makes their lives better. And later on talking about the really important issue of needing financing for these settings. But like all of us, those living in a humanitarian crisis need more than these basic practicalities of life. We all also need and deserve dignity, autonomy, and human connection. If we're living with a medical condition, we need not just medication, not just access to medical professionals, but we also need access to support to help us with the daily job of living with that condition. We need as many means as possible to help us to understand the disease we're living with, to cope with it, and to live the fullest life that's possible, even amid the crisis that we're enduring. And so on the panel today, we will discuss how we can work towards improving these human aspects of life and care of people living with diabetes in humanitarian settings, in a way that actually can also improve the medical care and medical outcomes through facilitating the connection of peers to support each other. I do invite my panelists to come up and join me. Over this past decade, humanitarian organizations like mine have been working on developing and implementing models of care for diabetes and NCDs adapted to the places we work. We use task sharing between, a variety of healthcare and lay workers. And we've recognized patient education as an important component of that care. And there are certainly examples of community components of care and peer support. But despite the general acceptance of the importance of empowerment of people living with diabetes, this key aspect of care is not the strongest part of medical humanitarian NCD care. I wanted to just show an empowerment ladder, which I find quite a useful conception of this, showing the levels or stages of empowerment from individual empowerment through to the ability to support the community, through to advocacy. And in the medical community, we often talk about this early aspect of empowerment, about the need for education for individuals. And in the humanitarian community, we've been increasingly talking about the real need for strong advocacy from people with lived experience. But I think this middle section on the community aspect, where peer support falls, is one of the bigger gaps that we have so far. So I personally don't live with diabetes, but as an NCD advisor in MSF for too long, for the last 10 years or so, I've been supporting teams who provide this care for people with diabetes. And I really wanted to have this panel because I really, fully believe in the importance of person-centered care that includes peer and community support. But I've seen that it's very challenging for our teams in including this as a routine part of care. Teams on the ground are faced with multiple competing priorities, limited time, and limited resources, making this aspect of care easy to deprioritize. It falls also outside the comfort zone of medical teams, and they who are more used to focusing on biological parameters and achievement of clinical targets. They also see that the populations they're supporting are often struggling with many challenges, including access to basic needs. And so taking on peer leadership roles may seem far from realistic. So we wanted to have this panel today to really learn from those who do have experience of peer support and its benefits. So those living with diabetes who have implemented peer support in various settings, as well as fellow humanitarian actors who have also managed to implement peer support in their programs and seen its added value. And I wanted to bring us on this journey to understand this as a IATA community so that we can help to move this important aspect of care forward. I don't want to frame the discussion too much today, since we have an expert panel who are going to show you that there are quite a range of methodologies and areas of support that can be adapted to the needs and adapted to the setting. And I won't attempt to define it absolutely, but to be on the same page, we can broadly understand peer support as a practical, informational, social, and emotional support exchange between people with lived experiences, such as living with diabetes, of course, and potentially other shared characteristics. And it's something that can complement and enhance other healthcare services by creating the emotional, social, and practical assistance necessary for managing its disease and staying healthy. And just before I move to our panel, I want to thank people who have supported me in preparing this panel, particularly Emma Klapman, who's working with us in IATA and has helped with the thinking around this panel and including bringing the lived experience. And there are a number of other people in the room and online who've also provided a lot of thought around this. And so to introduce our panel, we have Serene Farhat, who's the founder of Positive on Glucose and a global diabetes advocate with a diverse background in humanitarian aid, healthcare advocacy, and project management, based in Lebanon. We have sitting next to her Lars Brun Larsen, who's been working on NCDs for over 20 years and is currently a senior health advisor at the Danish Red Cross, focusing on non-communicable diseases in humanitarian settings and based in Copenhagen. We have Sana Amjal, who is the executive director of Meethi Zindagi, based in Pakistan. Um, we have Vivian Nabeda, who is the executive director of the Sonia Nabeda Foundation. And we have online Ramadan, who is a warrior coordinator from the Sonia Nabeda Foundation, who unfortunately wasn't able to join us in person. So Vivian is kindly joining us on the panel, but Ramadan will be presenting to us today. And as well online, we have Primitive Kajuju Ekunda, a medical coordinator support for MSF in Kenya, and previous NCD activity manager, overseeing the implementation of a project in Embu County in Kenya. So without further ado, I'll move to our first speaker, Serene, who's going to share with us her experience. Great, Serene, I hand over to you.
Hi, everyone. I always get a little bit anxious on stage, so bear with me as I catch my breath. Hi, my name is Sirin Farhat. I'm a person living with diabetes for um, almost 16 years. Yeah. So what I'll bring today is my professional experience and my lived experience to the table. I'm super excited to be here, and I'm really thankful to a lot of people here in this room because I would not be here standing amongst you if it hadn't been for them. One of them is Philippa, who picked up a comment I wrote in a Global Diabetes Compact Zoom call, and that's how I'm here, kind of. So thank you for that, and thank you for seeing value in lived experience because it really is the key that we're missing out in all the services that we provide to people with NCDs and people with diabetes. Um, there's one familiar face you see here, which is Muhammad. Muhammad has been with plasma glucose since the very start in 2020. So, a little bit of background. Um, I introduce myself. I'm the founder of Plasma Glucose, a small nonprofit in Lebanon that gives advocacy training, that gives coaching support, and that has a support group and helps formulate support groups because I believe in the power of peer to peer support, and I have seen it really influence the lives of a lot of people with diabetes. So, talking about humanitarian settings, I heard a lot of things from the panels before, and I was just having a conversation with Felipe, like, what is really humanitarian? Is it just a really horrific crisis that has just happened, a disaster? Or is it like in the case of Lebanon, where we've been living in a crisis for the past 5 years? Isn't that considered humanitarian? And do these people not deserve access to aid? When MSF started its clinics in Lebanon, they were first helping refugees, Syrian refugees, but now more Lebanese people, I think, are coming into the clinics, which really sheds light on the need for more access to care. In Lebanon, where a country is, it was really everything was subsidized by the government. The system was very privatized. People would pay out of pocket to go to hospitals and clinics. Now there's a shift where people seek primary healthcare clinics, seek NGOs, seek wherever they can get aid for free because they simply cannot afford to live a decent living and they cannot access medication. So, how do we help a population that is overburdened with problems for the past? I'm not just gonna say 5 years because in Lebanon it's it's ongoing. It never really stops. So we're going to talk briefly about who we address when we build these support groups and how we should really develop a model of care that empowers patients to use their voice and to have autonomy and to care for them for themselves. And funny enough, I was reading a book for Adam Grant. It talks about how you rethink things. And he was talking about a lot of biases that we have, confirmation bias, the I'm not biased bias, and how we, as professionals, when we practice things every day, every day, every day, we start kind of standardizing the way we deal with people to the extent that we really forget to listen. We're just listening to hear what we're used to hearing or to certain things. And we forget that these people coming into our clinics, they are human beings with lives and problems. Um, they're people. They're not just patients. And this is really important in shifting the way we look at how we present our care. So, what is peer to peer support? It's me living with diabetes, being supported by Muhammad or by anyone else here living with diabetes, coming at the table, sitting together, and talking about how nasty our low was yesterday, the headache we have because we were high all night, being worried about what if it bombs? What if a bombing happens? How do I store my insulin? If there's no electricity, how do I store my insulin? These things. And this is how we started peer to peer support. Weirdly enough, it was during COVID when we were all on lockdown and we had nothing to do but go online. We started our first online WhatsApp group that was called back then A1C support because we were 5 people who wanted to lower their A1C from all over the world. Muhammad from Palestine, we had a girl named Alyssa from the US, and other people. Some of these people are still with us today on the group. This group grew on WhatsApp. We had back then a dietitian who volunteered to help. And then we did our first Zoom call. Back then, I did not know it was a support group. It was just a bunch of people coming together every week to talk about diabetes in life and stuff. And we grew and grew and grew. And because of them, I pursued a coaching certificate because I felt like we're living with this burden. It's not really a disease, it's something that we have to live with. And that's why I say I'm a person living with diabetes, I'm not sick. It's something that I have to live with forever. I get no break from. It's heavy, it's exhausting. Add on top of that, I'm a girl that has different challenges than boys because I have different hormones. Add on top of it, I want to maybe have a baby. I want to get married. Add on top of it, I'm a Muslim Arab. So think of all the stigma. So this is how it started. We came together. I figured out that what we really need to do to help people with diabetes is not just give them a pen and test strips. Of course, it's monumental. It's the start, but it's not enough. What we needed is to ask these people the right questions, see their habits, see how they're living. What is going wrong? Why is there so many people with type 2 if we have all these tools for diabetes? There's something that we're doing wrong. And we have to rethink. I go back to Adam Grant, please read his book. We have to rethink our models of design. Like, how are we designing? What approach are we using? Why is it not working? So, bottom line, COVID, every day every week we have a call. Sometimes we would just go on the call and we don't want to share experiences. We want to just do something to blow off steam. So we play a game together. Really support in any way and form. Emotional support, shared experiences. It was the first time I got to talk about my pregnancy journey with women who had no idea how to go on a pregnancy journey with diabetes because no one talks about it. And now I talk about parenting with diabetes, which is also as exhausting. Motivation and empowerment. And I obviously read a lot of studies that show how support groups impact behavior, but none about type 1. Please, I invite you, do more studies on type 1. So we come to accessing peer support in humanitarian settings. I'm going to talk about the case of Lebanon. In Lebanon, we have mostly Syrian refugees and Palestinian refugees. Thank you, UNRWA, for taking in and helping all the Palestinian refugees. Thank you to all the other organizations that help with Syrian refugees. But now, with how the crisis is going in Lebanon, we see more and more organizations exiting. And the question is, what do all these people do when the organizations exit? Where do they go? Because in Lebanon, the national security system or the healthcare system does not cover people who are not Lebanese. Even if you register them, even if they're legal, they don't get benefits. Nonetheless, the system crashed anyway, so not even Lebanese get benefits now. But just talking about the big picture. So what do we do? There's no infrastructure. And in a lot of sense, there's a lot of stigma around how we deal with these people. Um, we have to find more innovative solutions to access them because a lot of them can't afford to go to transport from one location to another, from one clinic to another, if we want to access them and give them support groups. And basically, I at least haven't heard of any support group that targeted um, refugees up until maybe last year when I started working with MSF as a consultant and learned more about their initiatives and how they're trying to help them. And I think an even bigger question here for me arises is if I went to the clinic in Arsal, I did a focus group with the mothers, and then I went to Hirmel and I saw the healthcare practitioners. And one question was like in my head, now you have Lebanese and Syrians. How are you going to incorporate both these target audiences in one support group, given that there's a lot of tension between these two populations? So these are all questions that we need to think about. And this applies to any other support group in any other setting when there's different populations from different ethnicities and you're trying to help them out. And even sometimes within the one group, let's say Syrians, in Arsal, you would design the support group differently than how you do it in Hirmel, because it's a different, they're different people. They have more restrictions. For example, you would do a gender-based support group, one just for the women, one just for the men, because men don't open up in front of women. So these are all considerations that are very culture sensitive that we have to look at. So this is a picture from MSF in Beirut. We were recording a podcast. I invite you also to listen to it. This is Julie. She's also been part of Plasma Glucose ever since she was diagnosed at 21. Um, it's really beautiful to see how people can grow and flourish from being in peer-to-peer support groups. We have people within the group that hid their diabetes for 20 years, and once they felt supported, they start coming out and telling people in their communities. They didn't even tell relatives, very, very close relatives, about their condition. We saw people that hid it from potential spouses because they were afraid that they would be judged as unable to bear children into the world. And these support groups really help people flourish and show who they are and show their true colors and look at life like, you know what? Love me the way I am or hit the road. Take it or leave it. This is how I am. I have to inject 3 to 4 times a day. I have to test. I'm a burden, not yours. You can go. So this is kind of the atmosphere we wanted to bring to the table. We wanted people to feel empowered. We wanted people to have healthy habits. We would do sessions where we put smart goals, health goals, exercise goals, whatever goals they are. And we really saw people that were able to lower their A1C, HbA1c, just by being supported. Nothing changed. They didn't visit their physician. They felt able to be themselves, which is beautiful. I see remote peer-to-peer support as a potential key to maybe people in humanitarian settings that at least have access to some sort of technology, because as we see in the case of Gaza, the only way everyone got to see what's happening in Gaza is through social media. So they had some sort of access to technology. So we can still access people in their homes, even if they're miles away, because of technology. And maybe it's one method we can look into to make support groups more accessible to people. It worked for us. I'm here because of this. I never thought this would be my what I do for life, and now I'm here because of this, and this gave me purpose. So if one small WhatsApp group in 2020 got me here, imagine what if we do digital support groups and virtual support groups can do a lot to a lot of people in the world, and how welcome and loved it can make them feel, and how more they would embrace themselves and their condition and value who they are as people because others see them as really valuable. So I talked a lot. I don't think I really followed the slides 100%. But really, we try to really talk about support groups as much as possible in Lebanon. I'm already working with a couple of local organizations where we did support groups for people with type 2 diabetes, ages 50 to 80. And trust me, it's the cutest thing. Seeing a 75-year-old man walking into your support group session talking about how angry he is that he couldn't lower his blood sugar. But what is even heartbreaking, other than, cute and lovely, is the same person telling you, like, what you're telling me is great, but I can't really afford test strips. So how can I really better the quality of my life if I can't even buy test strips? So a lot needs to be done. I'm not going to talk about pharma and all these things. I'm doing a PhD on it, so I'll leave my talking to that. But there's a lot to be done. And we as a community can come together to do that. It's our role. How many people here live with diabetes? I'm really interested to see. Okay, and ever since you got here to Greece yesterday, how many weird thoughts, anxious thoughts you've had about your diabetes? This is just diabetes, not talking about life in general. So it's really, really important. Like we came together at lunch and we were nagging, like three of us, about things that have to do with diabetes. So it's so heartwarming to feel seen as a human, not just a patient, not as someone who's a burden to a system in Lebanon that is already burden. Um, I think, as I said already before, there should be cultural sensitivity to how we create these support groups. We should make sure they're sustainable and scalable. And when I propose on creating support groups, my vision is they should be done in cooperation with municipalities, which already have infrastructure, which already have systems that can bring these people together at least once a month. We really should talk about how we can make things more available for a lower cost, because that's how you make sure they will sustain and um, how they will work in the future. Um, so Basically, that's most of what I wanted to say. I have so much more to say. I'm more than happy to tell you all about my thoughts and side conversations. I hope this helped, and I really, really hope we, people in this room take whatever they're hearing here and take it outside, and really we start spreading this idea as a patient being a person with a life and with problems and with troubles, and that they lie and sometimes they pretend they're good diabetics at the clinic when they're really having the worst time of their lives, or they're battling hidden mental health conditions. Do I look someone who's depressed? No, but I am. Do I look like someone who has anxiety? No, but I am. And I live with these conditions just like I live with diabetes, and sometimes they take a toll over my diabetes. So we have to look at people as persons. Thank you.
Thank you so much, Serene. I'm going to take your comment, pens and test strips are not enough. And then you showed us how the power of that one-on-one connection, that peer support can help people to flourish, to get confident, to overcome stigma. You talked about the importance of trust. And I think for humanitarian actors, and part of this panel today is really seeing, what role can humanitarian actors play and what role does peer support play in humanitarian response. We know that access to care can often be challenged in humanitarian settings. And so your example of a WhatsApp group and Zoom calls and how well that function, I think is something that could potentially be extremely useful in humanitarian settings. But I really want to finish on your last point, because I've told the story many times, but um, if you will allow me, we also had the experience in Lebanon where our teams implemented a fun day for World Diabetes Day, where patients and everyone came and they celebrated World Diabetes Day. And when I asked the team what they took away from that day that they wanted to continue, because they were very positive about the day, they said, we learnt to see the patients as people. And so I think also, including this aspect of peer support can also help us as humanitarian actors also to see the people in front of us. So thank you for that. Ramadan Maset, are you on online? So we're going to move to Ramadan with the support of Vivian here. And Ramadan is working with the Sonia Nabeda Foundation, which is not in a humanitarian setting. It's in a low resource setting. But in fact, I think there are many lessons from this really interesting example that are potentially useful in humanitarian settings. And as we've already discussed today, many humanitarian crises settings, are protracted. And so let's see what we can learn from this experience. Thank you. Ramadan, over to you.
Okay. Thank you for this opportunity. Protocol observed. Good afternoon, everyone. My name is Ramadan Masete. I am a warrior and warrior coordinator at the Mbale Regional Referral Hospital. I was diagnosed at age of 12 years. In 2019, I attended my first SNF camp, Kunyala in Mbale. At the camp, I served as assistant camp counselor, assisting the counselor and team nurse. In 2020, because of the COVID-19 lockdown, warriors were not able to come to the clinic to pick their medical supplies. I volunteered to assist the clinic nurse and deliver medical supplies as needed. In 2021, the clinic nurse asked me to serve as a warrior coordinator because we had a good relationship and the warriors at the clinic trust me. Now I serve as a warrior coordinator and account counselor at our region camp. At Sonia Nagrita Foundation, SNF, we believe in an Africa where children with type 1 diabetes have an equal chance at a long, health, productive, and gainful life. Next slide, please. Who is a warrior? A warrior is a person with type 1 diabetes who lives with a great courage, perseverance, resilience, and optimism and inspiration to all. Next slide, please. Who is a warrior coordinator? A warrior coordinator is a warrior who serves as a peer support. In Uganda, at least one warrior coordinator is installed at each of the 33 non-led type 1 diabetes, depending on the size of that clinic. A warrior coordinator works alongside and under the supervision of a nurse or health worker. A warrior coordinator enhances the overall care experience and reduces the clinic workload for a nurse. A warrior coordinator leads peer support services. Next. Significance of the lived experience in type 1 diabetes. A deeper understanding of a warrior's experience fosters better communication between the warrior coordinator and the warrior. It has led to the improved support, trust, and shared decision making, ultimately resulting in a better health outcome. Next slide. My lived experience. There is Warrior X. He is 12 years old. He has been living with type 1 diabetes for 2 years now. Every time he came to the clinic, he always had high blood sugar. On checking his glucometer, it was clear that he was always high. On speaking with him, he said that his grandmother did not want him to inject himself and that she could pray for the disease to go away. So he was not comfortable injecting at home. I then planned a home visit together with my clinic team to meet the grandmother and together with Warrior X. I shared my story on how I was diagnosed at the same age, showed them pictures, and I even physically injected myself in front of the grandmother. Slowly, over time, she started to feel comfortable understanding that the disease is a condition and not a curse. I was able to build trust to continue, to allow me to continue to educate, support, and mentor Warrior X and his family. The severity and frequency of Warrior X's hypers has greatly reduced. Qualification of a warrior coordinator. At least 21 years old. A minimum of 5 years living with type 1 diabetes. A1C consistently around 8%. Provision in English and at least one local language. It's a citizen outgoing, willing to learn, and passionate about type 1 diabetes. Availability for 3 days a week with 1 year commitment. Next. Key responsibilities at clinic and the wider community. Type 1 diabetes education, peer support, community outreach, and advocacy. Next. Examples of peer support services. Warrior workshops. Twice a year at each clinic focused on specific subjects. Regional camps. Type 1 diabetes education and other support during, during the clinic week. Home visits based on our vulnerability criteria. Moderated digital community on WhatsApp. Each one weekend protocol. Next slide, please. Ongoing and continuous training. Annual training once a year to enhance skills and build a community of committed warrior coordinators. Topics include confidentiality, ethics, documentation, and leadership skills, listening skills, basic type 1 diabetes, understanding and mental health. Future initiatives, developing certification for warrior coordinators as diabetes educators. Impact and sustainability, better outcomes, community intent, reducing burden, long-term vision, a sustainable network of young warrior leaders in type 1 diabetes care that will contribute to the improvement of warrior health outcomes. The future is a world of warriors by warriors. Development of certified type 1 diabetes peer educator program. Expanding the reach and influence of warrior coordinators beyond the clinic and immediate community. Advocacy. Campaigning the needs of the type 1 diabetes community on a broader scale. Building a thriving community with warrior coordinators at the heart of type 1 diabetes care model. Ego, a world of warriors. Next. Next.
I think that's it, Ramadan.
Type 1 diabetes should never get in the way of a child's dreams. SNF, Sonia Nazeta Foundation, together we can for God and my country. Thank you.
Thank you. Thank you so much, Ramadan. That was wonderful. And I think there's a lot we can learn from this. I think it's a very interesting experience and interesting to think about this kind of example for humanitarian settings. I think incorporating, the person with lived experience into the medical team, as they showed, it also just helped a little bit. I mean, I mentioned at the beginning how teams are often overloaded and really just don't feel that they have the time to spend educating and explaining to patients and spending the time that are required with patients. And I think incorporating this into the team, but also bringing in a perspective that's not in the team necessarily, someone with a lived perspective is very interesting. And I think that the way the Sonia Nabeta Foundation is supporting in terms of providing the training, the certification, and also I understand helping sort of on the path to becoming advocates, I think is something very interesting and interesting to see if that could be applied in humanitarian settings. Thank you so much, Ramadan. So next, I'm going to ask Sana to come up. So Sana is working with Mithis and Dagi, and really interesting to hear the experience of how this started as an informal collaboration of peers that become then more formalized and then adapted when an acute crisis hit in terms of the floods. So thank you, Sana.
Thank you so much, Philippa. Thank you to Ayada for giving me this opportunity. Thank you, Sylvia, Emma. Um, I'd start with how I feel here being today. I've been to loads and loads of big conferences, and I always had this, feeling that I have to, really mince my words and I have to be less open. But the openness with which this meeting has been carried out is amazing. And I'll go forth with this presentation with a lot of open information, and I hope you'll enjoy as well. So, Meet Zindagi started as a very informal peer support group. I hope this one is working. I don't want to stand at one place. Yeah. Okay. So, it's a very informal peer support group. It started with a WhatsApp group with 5, 6 people. It it spread through word of mouth from different people knowing other people with type 1 diabetes within their area and looping them in. Um, the group grew to around 100 or something when we decided that it was too much to handle on WhatsApp. So then we shifted to Facebook closed groups. Then we divided our Facebook closed groups into multiple further groups because the young people wanted to have a group separate from the parents because they wanted to talk openly about things that the parents would, start probably judging them about. The parents wanted to, because we are, again, a semi conservative culture, so some mothers did not want to be in the same group with the males, so we had to separate that out as well. So there were a lot of, ongoing evolution of the whole group. This picture to me represents the essence of this peer support when we just all of us gathered on the beach one day, just sitting on the sand, talking about what matters to us, sometimes just talking about, again, as we said, the headache due to the hypo, or the stigma that we're facing, or the bullying that happens in schools with these children. Peer support is a very present reality in our lives every day. Just happened to me now. My sensor stopped working, and Muhammad rushed to his room to get me a spare one. So peer support works in such special ways. I remember at one conference I had to go, and I had to travel to another city because where I was at that time, there was no airport. So I had to travel to another city to catch my flight. And I forgot my glucometer test strips. Um, so on my way, I just messaged on that WhatsApp group at that time that I'm coming to Lahore. Can anyone lend me his or her glucometer and test strips? And there were 3 people standing at the airport when I arrived there with their glucometer and test strips. So that's where peer support really helps. And we can't be perfect. I have been, since the time I started this, I have been hearing this. Oh, but you are an advocate, you are an inspiration, your levels should always be perfect. Once I remember I posted about a very bad hyper that I had after eating a burger. Oh, but don't post these things because that just destroys your image. We are all humans, and I have my highs and lows all the time, and it cannot be perfect unless we ensure perfect technology and access to it for everyone. So I think we first need to start there. So Meethi Zindagi started as a very small peer group with pillar number 4 was the only thing that we cared about. But as we started growing, um, we decided, and as a peer group, we decided that we have to lay the foundations of a formal organization because the need in Pakistan was way beyond the emotional well-being and peer support only. So while there was nothing available for pillar number 4, there were a lot of gaps in 1, 2, 3, and 5 as well. So we grew into this organization with this 5-pillar model, but till date, peer support is at the basis of everything that we do. This is a small girl. We provide her with insulin. Her mother left her. Uh, Her mother left her when she was diagnosed with the father and the grandmother to take care of her. She was just 2 years old at that time. And she comes to my office to sometimes pick insulin. Although we deliver insulin to children's homes, this particular family made it a point that we have to pick it from your office because whenever she comes in, she'll peek through the door, pass a smile, see if I'm not busy. She'll just come rushing in and give me a hug. And her father says that probably she misses her mother. And when you meet her, when you just give her a hug, when you try to tell her that it's okay, and when you test with her and when you inject with her, she just feels good about it. Okay, so this is later we evolved into when we had been doing a lot of insulin support. So we are supporting over 1,000 children across Pakistan. And the model we developed, this model was developed by people with type 1 diabetes themselves, along with the health professionals who were on our board. I'll just go back one slide. So I was talking about the insulin support here. Um, when we were developing this model, there was a consistent push from even the board members who were not people living with diabetes themselves to start a medical care center. Like, let's develop a big hospital for type 1 diabetes care. And the type 1s on that board, they started questioning. So, for example, if you tell me that we develop this hospital here, it will serve an area of a maximum of 50 kilometers around it. That's where people will come from to get their support. But we don't want this to be just for this area. We want this to be for the whole of Pakistan. And they brainstormed the model that is now being used at our organization, where we send insulin supplies to children's homes, no matter where they are in Pakistan. So as long as a courier service can reach their destination within 24 hours from our office, we supply them insulin there. It's a cold chain courier service. When the floods came, the very children that we're supporting with insulin, and they did not have the fare of their own insulin because we were ensuring that they were getting theirs, they started calling me up. The family started calling me up. There were people who would come to our office and say, what if there are children trapped in those floods? So in 2022, 1/3 of Pakistan came under floods. There were heavy floods. 1/3 of the country came under the floods, and there was a 90 million population that was affected. It was a huge disaster. But these people, these young children who did not have anything to worry about for themselves, were so worried for other families who were trapped in those floods. And in the first 30 days, and I was listening to the panel earlier with Mohammed, it was a chaos. It was a complete chaos. We talked to relief organizations, many of them. I won't name any, but there were big organizations that we talked to. And the response that we got was always, there's too much to deal with. We have trauma to deal with. There is disease outbreak. There is um, infectious disease, a lot of infectious disease that is going on. There is food shortage. So we're working on the food shortage. And every time we would try to explain that food is as important, is probably less important with type 1 diabetes than insulin. And if you're delivering them food, but they're not getting their insulin, it doesn't make sense. But the numbers are small. So it's a 90 million population overall where they have to provide support versus a small type 1 diabetes population. And the service is complicated because you have to make sure that insulin is the cold chain is maintained and there is no disruption, et cetera, et cetera, et cetera. We know all the complications. So it was too complicated for them within that crisis of a bigger nature to care about a smaller portion of people who needed insulin. And we kept listening to either no's or sorry, we're going to get back to you in 2 weeks' time, in 3 weeks' time. Never happened. So what the volunteers decided to do was that we will go ourselves to camps. We'll go to houses in the area and we will find out who are people with type 1 diabetes trapped there. So you can see these pictures. These are some of our volunteers and team members as well who are visiting the camps and explaining to people, asking them if they know about any person with type 1 diabetes within the camp. We made announcements in mosques. We made announcements. There was a rickshaw that we, gave a loudspeaker to, and he went through the whole area announcing that if there's anyone who needs insulin, please contact us. There were our teams that visited each and every house in those areas, knocked on the doors, asked if there was someone they knew about or if there was someone in the house. And we had to deliver insulin on these boats at times or on foot where the road structure was completely destroyed. And they willingly agreed to do that, in fact offered to do that for the community. The relief organizations came in at a later stage. They came in after around 2 months when we had already started getting knowing to and to be honest, after 2 months probably a type 1 would not be there anymore if they've not had support yet. So that was it from my side, and I try to keep it as short as possible, but I'm willing to open to answering any questions that you may have.
Thank you so much, Sana. And again, showing the huge personal value to people living with diabetes of peer support, but then also showing very practical added value of an established peer support system that was able in a acute crisis to advocate for the needs of this forgotten or neglected, population in the crisis, and then to practically respond to their needs with finding the population and supplying insulin. So a really great example there, I think, also for humanitarian providers. Thank you. So we're going to move online again. And so now we have Purity, who's working with MSF based in Kenya. And she's been going to share with us the development of peer support within MSF support to NCD clinical care, and then further supporting the development of a community-based organisation to provide continuity of support after MSF left. Thank you, Purity.
Thank you, Philippa. Good afternoon. I believe you can hear me. I'll put off my video so that we can now have quality. So yes, my name is Purity. I work with MSF in NCD Community Initiative. Philippa, you're doing my slides, please.
Purity, if you can hear me, Purity, we're on the intervention slide.
All right. Okay, so I will just move through. I have quite heavy slides, but I will try to just be brief on them. We can discuss a little bit later when we have some time. So this is a map of Kenya showing an extract of Embu County and the intervention sites. Next slide. So MSF had a 5-year project in Embu County, and the main aim of this project was to decentralize and integrate NCD care in human health facilities. And towards the end of the project, which closed in December 2021, we had around 7,000 NCD patients enrolled in care, 11 health facilities, and these were being taken care of by clinical officers and nurses who were using standardized guidelines to manage the conditions. One of the main key advocacy again was the lifting of restriction on insulin, and that meant that insulin was available for diabetic patients in primary care facilities. But we also had establishment of patient support group, treatment literacy classes, and NCD patient advocates, which is how we were able to engage with the NCD community. And of course, part of the conditions that we are dealing with was diabetes, type 2 diabetes specifically, because type 1 had a very strong system that was being used within the public health system in Kenya, in Embu County. Next slide, please. So the establishment of the support groups for us was a continuation of lessons learned from HIV care, where we saw that patients or people living with HIV who were involved in support groups had positive treatment outcomes. And therefore, we started similar groups, disease-based groups. And so we had some groups for all conditions, including diabetes. And these are the groups that we used to create and engage patients actively in their management. Next. During the project time, we saw a large number of enrollments of type 2 diabetes. And Philippa has already mentioned about the beginning of healthcare workers and patient education. But we also know that most of the type 2 diabetes on orals will eventually will be introduced to insulin, and they require education on how to use the insulin and how to use their medications for them to achieve controls. So within MSF, we have the health promotion and patient support teams who then started to identify active patients, people who are motivated, who controls, blood sugars controlled very well, who are willing to be educated, and we would in turn educate people from their communities who are living with the same conditions. And so these are the people that MSF took up and trained in advocacy. Later, they became patient advocates and champions, and took lead in the formation of the community-based organizations. Next. We know, especially in our countries, that most of the NCDs, including diabetes, have a lot of stigma and discrimination attached to them. And the speakers before me have said that even within support groups, within these peer groups, they're able to open up and find safe places where they can discuss their personal, social, and financial challenges. So one of the key reasons for the support group for the NCD patient groups was a place where they can talk about their condition and find peer support amongst themselves and be able to deal with the condition or with the problems that they were facing in maintaining the controls. Most of the peer groups may not be recognized legally, especially in some of the countries, and so putting them in a well-structured organization like MSF was able to achieve, then promotes the ability to engage in advocacy, which is mainly to speak about their conditions, speak about their challenges, and increase access to healthcare, even at the lowest level, the primary health levels. Next. So the peer support groups for us helped us during the transition period when MSF was closing the project, and that has been the continuation to date. So those that were already in organized groups, the patient support groups, were then empowered to form the community-based organizations. And now here in Embu, we have two peer-led community-based organizations, which are the main advocacy bodies for NCD service delivery, but are also managing the community revolving pharmacies where patients are able to access continuous medication, even when we have stock of the NCD medication within the MOH system. So we have seen continued patient empowerment through the community-based organizations. We have seen increased access to medications through the community involving pharmacies, and we have seen advanced advocacy through the community-based organizations. Next. So the peer support groups then with the NCD patients and their readers diabetes became the leaders of the community-based organization, and these are the two main community-based organizations that we have in Embu. You see, we deal with type 2 diabetes. Most of the patients are older, so most of them meet in the communities. We don't have a lot of access to modern technologies, so just having these small groups of people come together, have their education, train each other as advocates and as champions, has seen the NCD patients, diabetes, set up a center stage in PCD and advocacy in Embu County. Next. So we have two main CBOs in this manage two main CRPs that NSF seed donation to, but just having them together in a structured way through the community-based organizations, they've been able to set out 7 pharmacies. And the main aim is to bring NCD care as close to the patients as possible. So in the far off areas, we have the satellite community revolving pharmacies where patients are able to access their medicine nearer to them. Next. So analyzing the support that MSF has given to the formation of the CBOs, the peer-led CBOs, we see that within organizations, there's a lot of technical support, and this can help to build structures and systems for the peer-led organizations to register themselves into recognized groups and continue with advocacy work, continue with patient education and peer support. We also know that within NGOs, we have a lot of expertise, and this can be used either formally or informally education to different groups of people for them to take up roles in leading the advocacy work, but also managing the community-based organizations. Within governments, we have formal systems that peer groups and support groups at the communities do not understand. So NGOs can come in to help maneuver the systems and ensure that the CBOs, the peer support, find places and spaces for them to speak up and speak out about their condition. We know for this to happen, they have to have money. Most of the times, like in our setting, most of the people living with diabetes are already retired, the elderly, so they don't have money. And therefore, NGOs can come in with budgets to support the activities and the registration of community-based organizations. Next, please. So in summary, I have picked a few lines that have been said. One, learn to see patients as people, and the second was a world of warriors by warriors. So just to say that for us to have proper engagement and for us to have proper care for diabetes and people living in communities, we need to engage themselves. There's nothing for people with chronic conditions unless they are engaged. And I think that has come out very well from the first speakers who are people who are sharing their lived experiences. But putting together these peer groups and forming a legal entity like a community-based organization creates power in numbers. And this can even speak out for the powerless in the communities, for those who have not yet come out to talk about themselves. And through this, we can create power and speak about the conditions. Advocacy through organized group is also very important, and organizations like MSF linking to broader stakeholders and donors for a greater involvement can lead to a fruitful experience on advocacy for people living with diabetes. And thank you.
This work. Can you hear me? I'm decided to sit up here with the panel instead. Thank you so much for that, Purity, and I'm glad that we were able to present, and we will have one more as well, an example of where a humanitarian organisation has been able to support peer support within their project, and Purity has showed us also the role that it played in kind of MSF transitioning out of supporting NCDs, enabling continuity of care for the community in the peer support way, but also in the very practical way in terms of access to drugs. And thanks, Purity, also for highlighting the specific role that MSF could play in supporting the peer support. So thank you. And so last but not least, we're going to move to another humanitarian colleague, Lars. Lars, I just give you the clicker. And so Lars is going to explain the experience of DRC that's been working in collaboration with LRC and LSHTM on implementing and documenting and studying peer support groups in Lebanon, as well as a broader work on development of a manual on peer support in humanitarian settings. So thanks, Lars.
Yeah, thank you, and thank you to Yara for inviting me to present some of the things that we're working with, and also thank you to you for putting me last behind all these powerful stories and powerful people. This is not going to be easy. First of all, I would like to credit some of the other people that have also been part of this. That would be the members of the Partnering for Change Partnership, which is ICRC, Novo Nordisk. We also have, luckily to have a London School of Hygiene and Tropical Medicine on board as lead research partner, and Lebanon Red Cross as our implementing partner. And then, of course, also a disclosure. Novo Nordisk as a partner in this Partnering for Change, they have funded the research and the handbook that I will also present. However, they have not had any influence on the research questions that have been asked, neither the outputs of the research or the handbook. Oh, that was too much. Just to put the Danish Red Cross in context, Danish Red Cross is a part of the Red Cross movement. Of course, we have our national activities, but we also act internationally. And when doing this, we are what we call a partner national society. So what we do is that we support our sister national societies in implementing and improving their activities. So we act as what we call a partner national society. We have 17 partners at the moment. In 7 of these 17 partnerships, we work specific with the NCDs and improving our sister national societies in working with NCDs and integrating NCDs into their sort of package of primary healthcare interventions. We tend to use diabetes and hypertension as sort of tracer diseases for sort of having a broader focus on NCDs in a primary healthcare approach. We don't deal with specialized care. That is not our specialty. We also engage in research, as I will present here, and also in developing tools and different analysis that we will find will contribute to the global discussions. Yeah, I don't think I'll not dwell too much with this one. It's about self-care, having self-care, the ability of patients sort of to deal with their disease, cope with their disease, and have strategies to manage their conditions. Self-care is what we do most when we do care. Healthcare is only a small part of care. Peer support groups can be an impactful tool to do this. That has been shown in high-income countries. However, not so much in low and middle-income countries, and very little in humanitarian settings, if any. First, what we have done in Lebanon in terms of doing research on peer support groups. Since 5 years, Lebanon Red Cross has worked with the peer support groups. And we, in the Partnering for Change, we partnered up with the London School to design and implement a model for peer support groups that could work with Lebanon Red Cross. This model turned out to be a social worker facilitated model in groups of 10 to 15 people with diabetes and hypertension. We developed a module or a model that included 12 modules that was supposed to be performed over 6 months. To evaluate this, we did a mixed method evaluation. We did qualitative interviews, focus group discussions. We have also gathered a lot of quantitative data, so both clinical data and patient-reported outcome measures. The peer support groups, the project has stopped now. So the peer support groups has ended. We have collected all the data, but we haven't analyzed all of it yet. So what I'll present now is mostly what is on the implementation and coming from the qualitative evaluation. And what we basically saw is not different from what Serene presented. That's what she wants to see from a peer support group. It's really the psychosocial benefits that sort of shows in the qualitative interviews that we have done with the participants. It's about building relationships. It's about having fun, coming together with other people that they can relate to. It's also about gaining knowledge from the social worker and using this knowledge to change habits. But it's really also, the support that they can give others, the support that they can get from others, and sharing equipment and other stuff that is important in managing their condition. The lessons learned that we got from it was that what really facilitated these positive impacts from the peer support groups was that we had these experienced, trained staff, the social workers, that was empathetic, that could build trust with the participants and between the participants, which also came from the selection criteria of these groups. So we would have people that would sort of match together in the group. But we also saw that some of the barriers to implementing peer support groups was the staff workload. A social worker can only manage or run a certain number of peer support groups. So you really has like a roof that you cannot break if you don't have enough social workers. It was difficult to find suitable spaces, and the participants had other priorities in their life. They had ill health, they had economic problems, and that made it difficult for them to participate in all 12 modules. So of course we would see some attrition. These are just some of the quotes that will sort of show that what the participants and the social workers experience from the peer support groups. Yeah, and as I said before, some of the key findings was that training in the facilitation, that's really key. Otherwise, you will not have a group that is well functioning. It's about empowering the people in the group and not do cathedral education. It's about having fun, include ice-breaking, group activities very early, also to build the trust. And also to diffuse this information to the families, because the families will be the ones that are supporting the people living with the disease. The next thing I would like to present and also launch today is a peer support handbook that we have developed through the past 6 months. This is a handbook that is based on the available evidence that we have, and through a desk research or desk review, an analysis of grey literature. We have done stakeholder interviews, including people with lived experience and including organizations that have people or is a member organization with people living with diabetes, like HelpAge and NCD Alliance, and a lot of expert consultations with humanitarian organizations and key personnel in these organizations. The handbook has 3 steps. So the first step is to plan and initiate the peer support group. So it's about the target population, it's about setting up the project team, it's about analyzing the context. The second step is about the implementation and adaptation of the peer support groups. So it's about developing the manual, the modules, training the facilitators. And the last phase is about evaluating and learn. So setting up your results framework, your M&E plan, how to do the continuous improvement of the peer support groups. The peer support group also include a lot of practical tips, exercises, reflection questions, further readings, and so on. And I put out some one pages on the seats, and you can also see a poster in the poster session where you have a QR code, so you can enter the web page where you'll find the handbook. Lastly, I have 3 key asks. So the first ask is that people are only patients in very limited time. So this is about recognizing the wisdom of people living with NCDs. They have a lot of knowledge in living with that disease. So including this knowledge and including this wisdom in the clinical guidelines that is being developed in the minimal service packages that we will also discuss tomorrow, I think that would be really valuable to include as a resource. When we're talking about resources, we're also talking about the community resources, using the community health workers, having them as part of the team when delivering healthcare. The other thing is also to early on start with patient-centered care in the curriculum of health professionals. So for the medical doctors, the nurses, and so on, learn about how to include the voice of the patient and see the patient as a whole person. And of course, lastly, it's continuing building on the evidence base. We don't really have much evidence on this at the moment. So engaging in research endeavors, we need to do that continuously. Thank you.
Thank you, Lars. Thank you for sharing the example of Lebanon, for challenging us at the end to remember to be people-centered, and for developing a handbook to help humanitarian actors for the implementation. I believe we have 15 minutes where we can have some Q&A, so that's fantastic. I'm going to give the first question to Emma, who's going to challenge. Yeah, sure. I don't know if we have other microphones. Perfect.
Yeah, whoa, that's a bit loud. I'm gonna just come up here because I'd like any brave people to come up and possibly put themselves out there and be vulnerable and answer maybe a challenging question. But this panel was just music to my ears, and I hope it was music to all of yours as well. Peer support to me is so important because it counteracts the something is wrong narrative. And I can say that as an advocacy professional, I thought that I was, well, as someone with lived experience, I thought that I was done needing peer support. But after around 25 years of living with diabetes, I realized that I needed it more than ever. And I have found it in this global community, and peer support can transcend borders, it can transcend countries, and it's just wonderful to see this panel for sure. And I think something that came through to me is, of course, we need to see patients as people. That's who they are. They are persons at the end of the day. But this is where I'm going to challenge the audience a little. I'm only an advocacy professional. Advocacy in diabetes is only a career for me, and how I've made meaning of the cards that I was dealt when I was young, because of the chances that healthcare professionals have taken on me, and those in positions of power have seen me as someone to collaborate with, not just a person patient, not just someone who goes beyond managing a disease alone, but someone to collaborate with. And so
I just asked the audience maybe, is there anything you have learned about peer support that you might not have known until listening to these panelists? Has anything been demystified for you? And, did the session challenge any assumptions that you may have had around peer support? Just going back to one of the first things Philippa said about how it can be challenging to empower peer support groups and elevate them on the empowerment ladder. So anyone who's willing to share their experiences and what they've learned from these life-changing individuals on the panel, invite you to come up.
And a warning, I know many MSF people I can pick on if you don't. Beatrice, please. Beatrice behind you. Oh.
Right, so I'm Beatrice Vedder. I work for FIND. We're an organization looking into better access to diagnostics. But since I left it a few seconds, Emma, for someone else to put their hand up to say something about diabetes and their work, and since no one immediately did, as far as I could tell, I just actually wanted to share personally what that panel has just done to me and my family. So my husband lives with a cardiac pacemaker, and he's been living with it for 30 years. And now that he's getting older, sort of he's just going to turn 50. So we're seeing the accumulation of the effect on his body, right? Lots of things wrong. He's not totally sick, but it's keeping us busy. And we never really thought about peer support, and he's not a person who necessarily wants to seek peer support, So I thought about myself, okay, maybe I check out what there is. And I just sort of just now multitasking, apply to a Facebook group to say, okay, cardiac pacemaker patients and their family. So you can tell I'm a bit emotional about this because it's also kind of new to me. So I wanted to thank the panel here for inspiring me to actually do that and think like maybe I need that too, right? And maybe I can inspire my husband in the years to come to seek that as it keeps us more and more busy in the years to come. So thank you for letting me share that.
Sata.
Sorry. So I repeat again. No, because anyway, I'm a big fan of the activism because of my previous life at TB and HIV. So that's perfect. I just want to extend this discussion, say like your final point, evidence based. And so, what do you think that this activism could bring into the life of the people with the diabetes? Now, allow me to ask my very narrow-minded clinical doctor's point of view. And so how does this improve to the access? How does it improve to the eventual control rate? Or is this their job or it's just the doctor's job? How do you put this? And if anyone on the panel can answer to this question, I'd really appreciate this. If my question is clear.
Love.
I hope I understand your question right now. Let's see. I think what we will be looking at in this research that we're doing now is that we have some patient-reported outcome measures that we will look into, and that would be treatment adherence. We also have clinical data, but we also have a measure of patient centeredness. So to the extent the patients experience that they're being heard. And it's going to be interesting to see if we will see any kind of changes in these two measures, and not only the clinical measure. Maybe we'll not see any clinical difference because maybe we don't have power enough to see that. But it would be great if we can see anything in the other two measurements on treatment adherence and patient-centeredness. I don't know, maybe even maybe you have some.
So since you just said, I, I think I completely see where you're coming from, and we have been questioned about this so many times. So when we started as a peer support group and evolved into a fully functional, registered, organized body, um, there were so many questions that kept coming back to us, like, what is the evidence behind peer support? How are you structured? How are you making sure that the outcomes are there? How are you making sure? So sometimes it's, again, and specifically in humanitarian settings, it is more important to deliver those results. Yes, it is important to carry out that research and build that evidence, but usually what I've seen is that peer support groups are very informal, non-funded bodies, and they do not have the resources to carry out the kind of research that would stand out to the academia to look at that. But there are so many testimonies. There are so many testimonies to impact on personal lives, to impact on, like, just I showed you for floods, like what Sonia and Better Foundation is doing. And I think that I would really invite the humanitarian, the big organizations, the actors here to do carry out research on this, to clarify to the world the value it holds. But I think before that, I'll also have a request to, maybe we need to stop questioning the reality and try to, build evidence to have more visibility about what's there, and we're not acknowledging that.
Thanks, Sana. Aveen, I think, was just going to compliment Lars.
Thanks, Philippa. So I'm Aveen from the London School of Hygiene and Tropical Medicine, and research and data workstream co-lead with Angelica. So we were the research partner on the project that Lars has just presented. And as I mean, you're alluding to, Dr. Seja, it's not that easy to show in a kind of a formal way the impact of things like this that are often very complex interventions. But the way we do it is do something called implementation research. So looking at many different outcomes beyond just the clinical outcomes like HbA1c and so on, but also looking at, as Lars said, patient-reported outcomes using validated scales that look at quality of life and that look at disability and functioning scores, as well as we introduced one about patient-centeredness. So you do this multifaceted approach and use multiple different types of data collection, adding on qualitative data where we actually try to collect those anecdotal, the stories of people, and formally analyze and present it as formal research, but adding all of those together and looking at implementation outcomes. So really important things that have been alluded to by the panel, like sustainability, scalability, what are the implementation facilitators, barriers, what can we learn, lessons that can be transferred to other settings. So we tried to do that kind of overarching type of study. And I think it does require funding to do research as well. It does require really strong partnerships. So between local NGOs, the big international organizations, academics. And so part of what we want to do in IADA is to harness all of the energy in here and to together create a kind of research agenda that we can all work on together, including looking at peer support. So thanks.
Thanks, Aveen. Mohammed.
Yeah, thank you. Well, thanks so much, Avin, for kind of elaborating how such research would work. Because for Dr. Saita, we know, well, actually, 2 months before what happened in October and what's going on in Gaza at the moment, in one of your favorite clinics in Gaza, the Swedish one, we've started a peer support educational group activity with teenagers with type 1 diabetes in that clinic, actually with two groups and their families, their caregivers as well. And we've conducted, so like we stopped at 6 weeks. I was there for the first 5 weeks leading this whole thing because of the concept of peer support as a person with diabetes myself and a healthcare professional. And throughout those 5 weeks, we've seen significant improvement on the numbers that on the blood glucose levels for those patients. We were willing to start within the clinic itself to do HbA1c testing to see the improvement on HbA1c levels for those patients and quality of life levels with the diabetes distress questionnaires and quality of life questionnaires to make sure that what we're doing is actually improving their lives. And we've seen actual results where people, the Gazan community, how conservative it is. One of the groups were all girls, teenage girls, usually not talking about their diabetes to anybody else. And before we even before we wanted to introduce the idea of peer support and WhatsApp groups or something to connect them together, we've seen 6 or 7 of those girls connecting together and planning to go out and discuss diabetes by themselves without even us asking to do it. And it's all, again, the power of peer support itself. So it definitely works. And again, yes, when there is it's not about academic evidence. When we see a reality, we have to believe that reality. Evidence and research is gonna definitely support what we're doing, and it's gonna put more emphasis on, okay, how can we kind of get the work that we're doing on kind of a much bigger scale. And it was something that we were planning to do in different clinics in Gaza, and actually all the 22 clinics of UNRWA clinics in Gaza. But yeah, hopefully we'd be able to do it in the near future. But yes, we've yeah.
Thank you so much, Mohammed. I'm really sorry. We've got more super interesting questions online. We've got the audience. We actually are unfortunately out of time, unless I can borrow. No, okay. So sorry, Serene, we're out of time. But before I do a very quick wrap up, I just want to ask the panelists to give us one key message, a take-home message for the audience that Emma has already challenged to really think about what they've changed in terms of what they've thought about peer support today. So if you'd like to just go along.
I think I'll speak for Ramadan. If that's okay, Ramadan, you can wave and just say, Vivian, you can be my proxy. I think on behalf of the Sonia Nabetta Foundation, I'd say we believe in a world of warriors by warriors because one, in Africa, we face chronic capacity issues in type 1 diabetes. And so if we don't empower, educate, and equip the lived experience to support that capacity, we are wasting a valuable, partnership. And so we believe in that world very much. Number two, I think that ownership, the way we work in Uganda out of the 33 clinics, we want to galvanize the community to believe in type 1 diabetes as a condition that can be lived with successfully. And so that sustainability model where the warriors are invested, the community is excited, that is going to help us live beyond the NGO that we are. All these donation schemes have an end date. And so we want to believe that by involving the warriors, galvanizing the community, continuity and sustainability is possible.
Thank you. You snuck in two. I'm going to ask them to stick to it. It's fine. It's fine. Purity, would you mind giving your key message, take-home message?
Thank you. So what I say is that peer support groups work. And I'll go with that statement that let's see patients as human beings, as people. And through the peer support group and what I see them achieving within the small groups keeps me motivated and keeps me working towards seeing that support groups are formed in every community. But it's true they require funding, they require people who can work with them, who can mentor them. So let more and more NGOs get involved in trying to see what it is that the peer support groups are doing and what it is that what are the gains for an individual person rather than the scientific proofs for cohort controls and all that. So yes, let's continue and let's look for funding for peer support groups and let's promote them to levels that they are registered and that they can take an active role in managing and in advocating for their needs.
I'll be very quick. Philip is under stress. So one point, the only thing when we're developing the research and the guidelines for how to, scale and make peer support sustainable, et cetera, et cetera, et cetera, one thing that I'd really want you to think about is that bringing in too much structure to peer support will lose its value. So think about something where there is structure enough for scalability and sustainability, but it's also organic enough to be, really connecting to people and their lives.
Slim, I hope you are still listening in. For me, a key ask would be to include peer support groups in the minimum essential service package that we're talking about.
I'll leave you with a quick takeaway. You don't know what you don't know. So there's always something you're unaware of, and you're probably unaware of that. Um, really be open to new ways and new models of care. And if you want to work with people living with NCDs, you probably want to listen in to one of the groups informally and see how it looks like for them before you make any decisions that affect their lives. Because as the WHO says, nothing for us without us. So you can't really decide for us if you don't know how our lives are. So if you want to design a peer support group, figure out how it feels for us and what we need, not what you think we need. Thank you.
Thank you so much. That was a really special, powerful session. Thank you for sharing your experiences, for your vulnerability. It's really extremely important, and we hope to do a better job of it in the future. So we're a little late. We're gonna break now for coffee and posters. We're gonna start at 3:40. But we have 3 online speakers for this next panel, so we need to be back in here and starting no later than 3:40. They're calling in from the US and have other kinds of, so we can't be late. So please enjoy the posters for a bit, have a coffee, and come right back. Thank you.